Healthcare workers, the cumulative total since January, 3,485. With that, we have some resolved cases, quite a few in Ontario, over 15,390 resolved cases. That's 74%, and that's a very good news story there. The hospitalizations pretty well staying about the same. 1,025 people, down 2. Number of people in ICU, 192, down 2. And those in ICU on ventilator, 146, down 1. So I would say that means they're pretty well level or plateaued. We still tragically are seeing deaths related to that. We've had reported since yesterday 56 deaths from the previous report, for a total of 1,725 deaths since the outset of this outbreak. Long-term care homes, we have our 150 active outbreaks in the data here, the IFAS data. Meanwhile, there are 58 resolved, so you'd have to subtract that. That was an increase of 6 from yesterday's report. Still 1,239 deaths total have been reported, with an increase of 4. So that's not as many as we've seen other days. So that's a positive for that day today. And we still have our 4 deaths among staff related to long-term care homes in that regard as well. In retirement homes, we have 72 that are reported an outbreak in that regard. And basically, that's a slight increase of staffing, a positive 4 less in residents, so some data corrections there, and an increase of 2 deaths to a total of 165. Our tests, we have a total of we're just under 500,000, 459,921 tests done. Today's amount was 11,957, with 10,811 remaining and coming in more. Like other weeks, we come down and we sort of start to go back up again as we get to midweek. It seems to be the pattern as we have to drive towards completing the survey in the long-term care homes, which we're getting well over basically tests being done in homes, 70%, heading towards, we think we're going to make our goal of completing the full task by this Friday, with a large number of residents already done. And that's tests submitted, still waiting to be processed in that regard there. So that's been a good result from a lot of hard work and a lot of tests and cooperation with the residents and the staff in order to give us a good assessment. And we'll have to look at that analysis to see how does it show out as far as the variation across our different homes, the so-called red, yellow, and greens, and to see how that deals with our outbreak management with our IMS table, as I said, that's dealing with the outbreak and managing the various components and strategies to mitigate the impacts of the outbreaks and try to keep the morbidity and definitely try and get the mortality down in this ongoing event there. So that's our testing aspects there. And as I said before, we're still seeing this sort of undulating trend coming down. We hope to see the numbers dropping down a bit more as the week goes on. In that, the testing capacity will still a lot pending, stop more coming in. And we hope to process those through shortly and to get to that. And then looking at strategically where we want to do some further testing once we complete this task, which won't be the lab testing will be completed well into the weekend because the samples are still being taken up until Friday in the survey of the long-term care homes, and then they have to be sent in and processed accordingly over the weekend. So those are the main things there, and we tend to watch the other metrics in there with our positivity rate going down to the low 3%, and that's a good sign. Our R0 is hedging down a bit lower, dipping under 0.9, in some areas a bit lower, so that's good to see. As well as our case contact is doing well with heading towards the 90% mark. So a number of good positive indicators in there, and as I said, the number of tests positive today is part of that day-to-day variation, and we hope to see some continual improvement as the week goes on. So with that, I'm going to open up for questions.
Okay, we'll move to the phone lines.
Your first question comes from Miriam Adali with Radio Canada. Please go ahead.
Hi, Dr. Williams. I just want to start by asking you to set the record straight. Are we in phase 1 of the deconfinement plan of Ontario, or are we going to start in the next few days?
So, yes, the terminology in the document, the recovery mode, phase one is the pandemic phase. Phase two is the next move out of pandemic phase, and that has 3 stages in it. So, so phase one is where we have been up till now. We still are in phase one. And then when we go to phase two, then the first step is a number of those 2 to 3 or 4 week steps, stages that we talked about, and that will be stage 1 and stage 2 and stage 3 of phase 2 in that plan.
My follow-up question, Dr. Williams, is doctors today said that you are in discussion together to know if you're going to recommend loosening up the gatherings from 5 to 10. What would encourage you to recommend loosening up the gathering criteria?
So when we look at our public health measures team, when we're looking at the metrics there, remember the main thing is that when we were turning up the dial, we used to talk about the dimmer switch, when we had the numbers at 100, we dropped down to 50, we dropped down lower and lower. As we saw the amount of community spread that was going on, and we couldn't do the containment with the case contact management, especially with the large influx of unidentified cases from the United States in and around and after the March break, we then said we're going to have to drop that down to a number low enough and ask people to do the physical distancing, the social distancing and other terminology. And so we went for 5 and under to allow for a family unit or household unit. And we've seen that that's been quite effective in bending the curve, both in our hospital indices, admissions, ICUs, and deaths in that regard. So that has been effective. If we're going to turn the dial back down again, we would do it almost like slowly back the other way. And then if you're going to allow something different, what would you do? So far, you see we've allowed a number of other business type aspects to, besides the essential business, because remember we did roll back from business and construction to essential business to essential construction, down and down, and we moved those back up again. But they're still in the first phase, which means maintain the physical distancing. If you're going to do it, can you do that? Can you, if you can't, can you wear proper protection in that line there, especially if it's an essential duty and responsibility? But we still want the physical distancing and the 6 foot. That's why the curbside retailing, how's that going to go? Is it working well? Is it not working well? The wider construction. What's the occupational health and safety that encourages workers to have that distancing or proper protection in the moments when they can't be further than 6 feet apart? So in that sense, some of those things are turning down the dial, the restrictions a bit, but still under that caveat. So when we get to the next one, we would say, okay, what are we going to allow as far as some wider connectivity of the public engagement? That what would that be in a way that would not allow us to have to do a 180 all of a sudden, but to open it up and turn the dial back a bit. So we're hoping to have some recommendations as we continue to watch these numbers and see if they are slowly coming into the correct metrics that we're looking for, the combination of the data points that would convince our modelers as well as our public health measures table to say we can now move into stage 1 of phase 2.
Okay, next question.
Your next question comes from Antonella Artuso with the Toronto Sun. Please go ahead.
Thank you. Hello, Dr. Williams. A while back, you talked about modelers saying that there may have been a peak in long-term care. Ontario is still seeing cases, new outbreaks daily in that sector. Is there any evidence that the curve is flattening in long-term care?
The data we're looking at actually falls fairly close to what the modelers is, that we saw the cases had peaked, the number of new cases had peaked, and they are coming down. And then we're waiting to see, it looks like, as was predicted, that would be in the 2nd or 3rd week of May, we would see the deaths peaking and coming down as well. The last few days would be supportive of that, but I would say it's a bit premature to conclude that totally, because the deaths will always follow after the cases peak in that, just because of the epidemiology and the normal pathological course of the disease. So I think they've been fairly close on that prediction, and we will be affirming that soon.
Follow up?
Thank you. Yes, thank you. The Premier today talked about entering, I take it, stage 1 of phase 2. Is that based entirely on what's happening in the community, or does what's continuing to happen to some extent in the long-term care sector impact when things will open up?
I would say more primarily it's in the community, because in the long-term care we're dealing with an outbreak within an institution that can be contained within the institution by limiting staff movement, as we've done, limiting transfers in and out of the long-term care homes, limiting visitors, as we have done. So you should be able to contain that. What we're more watching about entering stage 2, and stage 1 of phase 2, I should say, is when you're recovering and you're opening up the province, it's the community writ large that you're doing. And so you want to pay more attention to the community cases. Can you contain those? That means, can you monitor every case and contact to make sure that they're all epidemiologically linked, is the term, and so that you may still have cases in the community, but they may be that some people inappropriately had a gathering of 50 to 80 people and someone was infected and infected the group, and so you have a whole bunch of cases. That would look like you raised the cases in the whole area in the province, but in essence then you had a contained outbreak if you can map that off quickly and saying all these people here go into isolation, all these people have to wait to get tested and assessed. So we want to watch those community numbers before we go to that stage 1 of phase 2.
Follow up? Oh, sorry, next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hi, Doctor. Just to follow up on one from last week, we keep talking about this problem with getting tests from assessment centers and whatnot to the labs on the weekends and the missed capacity that results in. The government has all sorts of emergency powers. Why can't it arrange transportation on the weekend? We get online packages delivered here on the weekend at my house.
Well, yeah, as I said, Rob, that was part of when we were looking at those numbers and various steps along the way. Those tests that we're talking about, they're not from assessment centers, they're from laboratories. Remember, we've enlarged our network and we have a number of community-based laboratories, private ones, and they have set systems that they put in place a long time ago for their pickup and deliveries and courier services. So that is a problem. And as I said, it's not someone asked this excuse. No, it's a system issue. It has to be addressed. And so we've tried to address that to some extent, so we haven't dropped down to the low tens. We've got some there, but there's still the ebbs and flows of all the samples coming in, and that may wane a little bit as we do the final pickup and the last testing of the staff and residents of the long-term care home. So there's a lot of metrics involved there, but each issue has to be addressed, whether it's swabbing, swab available, staff doing it, different people coming in, the proper labeling, mislabeling, going over to get the test done, the tests submitted, the results going in, the data entered properly. All these are part of a complicated big survey system, which the numbers sound simple, but the mechanics of it are complicated, and each step has to be done correctly.
Follow up?
Okay, thank you for that explanation, Doctor. Just a quick follow-up. We were asking the Premier earlier about when do we get to random testing. So he said we have to finish the nursing homes and their workers first, and then we move on to retirement homes and other congregate living settings. When do you envision us getting to random testing? So that, for example, I know other jurisdictions, for example, are testing grocery store workers. So when are we going to see this wider community random testing begin?
I would never say our testing just gets random. I would say we're going to do testing that always is done with a planned process and what we're looking for. So when you're testing something, you're doing it for a reason. If you're just going to test and do nothing with it, then why are you doing the testing? If you have an intent of why you're looking at it, that you're going to take some actions on it. So, for example, you gave an example there. If you see that you have a large number of cases that are related in the one you gave, seems like people, the only contact they have was in a grocery store, you say, well, let's test a bunch of grocery stores, and saying maybe there is a number of staff that are positive, unbeknownst to them, maybe they're asymptomatic. Why? If you find that, you're going to do something about it. You have to do something about it. To pick a random tester group, you say, well, let's pick this group because we know there's no one positive, and it'll just make the test look low. Someone say, well, that's a little bit of false mathematics. You shouldn't be doing that. And that would be correct. So I would never say our testing is as random. It has to be thought through. It has to be targeted because it's a fairly investment of time and energy. And you want to test a hypothesis and do something with the testing results when you get them.
Next question.
Your next question comes from Siobhan Morris with News Talk 1010. Please go ahead.
Hi, Dr. Williams. I wonder, as we're talking about moving into a different phase of, or moving into a phase where we're reopening things, are you going to give a directive about masking, whether it be for people patronizing businesses, for their employees, and why or why not?
We're working on those recommendations now. We have been working with our counterparts at the federal, provincial, territorial level. And so we're trying to look at how we would recommend the use. I think what you're getting at here is of the non-medical cloth masks. And when would we recommend that the public use them, under what context, what circumstances, and how much consistency should they do in that, so that we can be clear on what we're recommending, why we're recommending, and then be consistent in following that with educational processes and utilization, because part of that is an adjunct into assisting, let's say, as on a precautionary basis, as you start opening up and you have more public interaction. It may be situations where more and more the 6-foot distancing will be temporarily violated. And then so can you overcome some of that with proper use of masking? And we said that already, that if there's a situation even now where, because you have to be out and around, and you may get yourself into a situation, or you're anticipating you could be in a situation where that for a period of time, I don't mean for a couple of seconds or just passing by, but you're in a setting where you know you could have to be close to someone quite for about 5-10 minutes, then you probably should be wearing a cloth or face covering in there. We're not pushing for the use of medically indicated masks, which we're always working at supply. Those are for healthcare providers, and people are involved in the necessary essential works. So we have to make sure we hold on to that resource and use that for that group. But these other ones can be used with an action of other things, such as distancing, and in the right context and the right way. And we're hoping to give information on that. How does one obtain one? How does one care for one? How does one utilize it properly? How does one wear it properly? All these things we have to come up with, so it's not just hit and miss and the public are left confused on the matter. So we're working on that as even now.
Follow up.
And is that going to be a clear direction, as opposed to, you know, if it makes you feel comfortable, then you can, like, more like we recommend that you should do this?
Well, already we've put some direction there, as I just said, where I'm saying if you're going to be in a situation where you're going to be compromised, if you feel like it, wear one. No, I said if you're going to be in a situation where your 6-foot distancing is going to be compromised, then you should wear one in that sense. So that's more than just if you feel comfortable with it. So we're saying, but at the same time, we're not saying if you wear a mask, then you can just forget about the 6-foot distancing. That's not the message. The message is still, if you can, maintain the 6-foot distance. So it's not to exclude that, it's to support that.
Next question.
Your next question comes from Cynthia Mulligan with City News. Please go ahead.
Hi, doctor. I was wondering if you could tell me if you have any sense of where COVID-19 or the prevalence of COVID-19 province-wide, the cases that aren't symptomatic. Do you have any data that would suggest it's 10%, 15%, like where we are in this?
Okay, so when you talk about prevalence, you mean the active disease, and that's a challenge with COVID-19 because, especially with our younger population, they may have it and only actually carry it for 1 or 2 days or even less than that. And so it's a matter of prevalence how much is in the population at any one moment. Our current COVID-19 testing can never measure that. It can give you incidence, and the negative today may be positive in 2 or 3 days. So it doesn't tell you that. What you're asking for is the best way to say prevalence is with a serological survey, to say if you do a population survey and test people and you find 10% of the population, even some who said, I don't remember any symptoms, are now have immune status, the conclusion is that that 10% of the population was exposed sometime to COVID-19. So I'm saying the difference between prevalence and incidence, Like some in the prevalence of diabetes is it stays a long time and people have it. How much is in the community? Incidence means the number of new cases diagnosed. But in the testing of our current methodology of the nasal pharyngeal swabs, that tells you what it is at that moment, not what it was a week ago or 3 weeks from now. And sort of assess that, we have done some studies. For example, remember we did all the ones where people just went to the hospital for other reasons, and we did the parallel testing, and we found basically out of a lot of many thousand tests, only one or two that were sort of there. We've done some other ones even now with our long-term care homes where we're testing some facilities that have had no cases reported, no outbreaks reported. And how many we want to test to say, how many of those did we find cases among staff or residents? Because they would have to say, I was not symptomatic. So in a way, we're going to be testing and looking for that among that one. It's a fair large population, and we continue to do others from other centers. So we keep looking at samples of the general population to say, in that sense, if we're finding positives that had no history of travel, no history of contact, no history of any symptoms that they can remember, therefore then it just arose. What percentage is that? So far, the data we have is it's low, in like the 1%, a very small amount. And some other kind of provinces have done larger scales, and some people, like someone did all the hospital ones and found zero. So the asymptomatic one as being a hypothesis of a lot of them moving around. If it is, it's not a large contributor to our conditions. It's very much evidence that those that are symptomatic are positive and are transmitting in that regard. Even some can transmit a few days before, because when did your symptoms start? They said, well, it started yesterday. Maybe I felt a little bit off the day before or the day before. If you ask people to recall, they say, okay, I guess it started back a few days ago. So it's people's recall and ability to say what was significant in their minds. So there's a lot to be learned on this, but we're going on the assumption that people could be shedding before they become knowledgeable of their symptoms, and therefore we need to understand that in our evolving epidemiology. But so far, we haven't seen a lot of evidence, and I think if we're going to look at overall population prevalence, we're waiting for a good serological test to then do some population surveys to say, what is the average overall exposure in a population, and doing a cross-sectional study. And that's what that special task force is being put together with at the federal, provincial, territorial level, where we have Ontario experts at that table, and they're going to be answering those questions and looking at that coming up.
Follow up?
And just quickly, thank you very much. Do you have a timeline on when you think a serological test will be in play?
Well, that's the question we're asking the committee, because they're not only looking at the how to do tests, but looking at the tests. And they've done a lot of clinical tests and studies on many different ones that are promoted. And a number of them so far have not been equal to the requirements we would have as far as their sensitivity and specificity to be of use. It's not useful to doing a test that's sort of like 50-50. I mean, it doesn't really tell you. It may tell you if it's positive, but if it's negative, it doesn't tell you anything. That doesn't help you with a population assessment. So we have to really trust them and with our leaders at the National Microbiological Laboratory. They're doing all their studies with this expert group to say, if we got a good product, here's the one we're going to roll out and do. And we can do that not only provincially, on a national basis as well.
Okay, we're going to move to our last reporter.
Your final question comes from Colin DeMello with CTV News. Please go ahead.
Hi, Dr. Williams. So the Premier, as we've discussed here, says the province is about to enter stage 1 of the economic recovery plan. I'm just wondering from you, do you feel confident that we've met the threshold to actually enter the first stage of that recovery?
No, I would have recommended we were already there, but we haven't yet. So that's what I was explaining to the other people, that we're on our downward trend. We're in about day 7, 8 of a sort of a downward trend, unfortunately not a very rapid downward trend, but it's tending that way. Our other metrics are looking good, but we haven't had all those things come together yet where we say, now we're ready to enter stage 1. I think we're getting closer in that, but if it was already there, I would have already recommended it.
Follow up?
Okay, thank you. And just looking at other regions in the world where we're seeing restrictions that have been lifted, an uptick in new cases, and then, of course, they have to go back into a lockdown. I know that that's kind of the pattern that we could follow here, but I'm just wondering about the threshold for reintroducing measures. So once we reach stage 1, as an example, I know you're going to be doing a lot of surveying to see whether COVID-19 has spread. What is your threshold for the number of daily new cases to say, okay, we need to reintroduce some of these measures?
Well, all along, as I said, when we were going back a while now, all throughout February and March, unlike some other centers, we were impacted by a lot of potential and real imported cases coming into our naive population. And then we were, with the cooperation of the people who came forward very responsibly and doing a lot of case contact management then, because then we found some individuals who had come back from country X, Y, or Z, found out they were positive, and some had been very vigilant, stayed home, did quarantining because they suspected they might have been. Others didn't even know the country came from had an epidemic going on. And some said, well, I went to this event, there's 50 people there, I went to this one, I went to that store. So all of a sudden you got 500 or 700 people to follow up. We did that with good case contact management and contained it. As a result, they could have spread really further, and we could have already been way higher numbers than we have. When we got above about 130, 120, 30 cases a day coming in, and we had that big influx from people who just came back and didn't know there was already some cases and was rising up in the U.S., the Eastern Seaboard, we soon got overwhelmed with that, and we started seeing those community spread cases where we couldn't do the epidemiological linkage. Our point will be when we get bound to that level again where we can contain it, because then if you have second waves, another one coming up, you quickly jump on and you contain that. If again you can't contain, then like you said with other countries that may not have as a robust case contact management, then they have to then revert back again and put in those measures, turn the dial back up again, put people back into lockdown, that kind of stuff, because that's your tool, the only tool you have. If you have a very aggressive and very assertive, I say aggressive as in not being aggressive as in angry, but as one that's very target driven, very thorough in its investigation and protecting the individuals, protecting their family members, etc., that you contain it, whether it's at a family level or a group gathering or an event, then the public at large are protected, and you don't have to reverse your public health measures. The key is you have to contain it.
Okay, thank you, everyone.